According to Dr. Yogesh, the signs of connective tissue disorders, CTDs, present as a multi-system puzzle. 1. Let's start with the general signs, which are common to many CTDs and reflect systemic inflammation and chronic immune activation. First, look for a low-grade fever, which is due to the release of cytokines like IL-1, IL-6, and TNF-α, and is often seen in conditions like SLE, RA, and vasculitis. Another sign is pallor, resulting from anemia of chronic disease, where iron is sequestered and red blood cell production is reduced. You might also find lymphadenopathy, which indicates immune hyperactivity or a secondary infection and is common in SLE, Sjogren's, and mixed CTDs. Finally, weight loss or cachexia can occur due to the catabolic state caused by chronic inflammation, especially in advanced RA or systemic sclerosis. These signs are often subtle, but when several are present, they strongly signal systemic involvement. 2. Next are the musculoskeletal signs, as CTDs frequently target the synovium, muscles, and surrounding structures. This can manifest as joint swelling and tenderness, typical of synovitis in RA, or the non-erosive arthritis of lupus. Over time, this can lead to deformities. For example, ulnar deviation is a classic sign in RA caused by chronic synovitis. In lupus, you might see Jacquard's arthropathy, which involves reversible deformities due to ligament laxity. Beyond the joints, look for proximal muscle weakness, which points towards inflammatory myopathies like dermatomyositis or polymyositis, as well as muscle tenderness or wasting from chronic inflammation or disuse. A simple way to remember this is RA twists, lupus bends, myositis weakens. 3. The skin often serves as a window to systemic autoimmunity, presenting many mucocutaneous signs. The malar rash, a fixed erythema across the cheeks and nose, is a hallmark of SLE. Discoid rash and alopecia can indicate scarring lesions in cutaneous lupus. A heliotrope rash or Gottron's papules are pathognomonic for dermatomyositis. In systemic sclerosis, you'll see sclerodactyly, which is tight, shiny skin due to fibrosis, and telangiectasia, which are dilated capillaries. Calcinosis cutis, or calcium deposits in the skin, is seen in Crest syndrome. Oral or nasal ulcers can also be a clue. They are typically painless in lupus but painful in Behçet's disease. Another sign is livedo-reticularis, a net-like skin discoloration seen in antiphospholipid syndrome. These visual clues often precede systemic symptoms, making their early recognition key. 4. Vascular signs are also crucial, as microvascular dysfunction is central to many CTDs. Raynaud's phenomenon is a classic example, with its triphasic color change of the digits: white for ischemia, blue for deoxygenation, and red for reperfusion. Ischemic damage in scleroderma can lead to digital ulcers or pitted scars. Examining the nail folds can reveal capillary changes like dilated, tortuous loops, which are seen in dermatomyositis and systemic sclerosis. These signs are important because they reflect endothelial injury and can help predict systemic involvement, such as interstitial lung disease in scleroderma. 5. Finally, we have the systemic signs, where organ involvement defines the severity of the disease and guides management. A. In the respiratory system, inspiratory crackles may suggest interstitial lung disease, common in scleroderma and myositis. Pulmonary hypertension, seen in Crest and scleroderma, can present with exertional dyspnea and a loud P2 heart sound. Cardiologically, a pericardial rub could indicate pericarditis in SLE, while murmurs might point to valvular involvement or Liebman-Sachs endocarditis. Signs of heart failure can be a consequence of myocarditis or pulmonary hypertension. Neurologically, seizures or cognitive impairment can be manifestations of neuropsychiatric lupus. Neuropathy, whether vasculitic or demyelinating, is seen in Sjogren's and MCTD. D. Ocular signs include conjunctival redness and keratoconjunctivitis sicca, or dry eyes, which is characteristic of Sjogren's syndrome due to lymphocytic infiltration of the lacrimal glands. Similarly, in the oral cavity, Sjogren's causes dry mouth and parotid swelling from autoimmune destruction of salivary glands. E. Lastly, in the renal system, hypertension or edema could signal lupus nephritis or a scleroderma renal crisis, which may require urgent immunosuppression or ACE inhibitors. Recognizing these multi-system signs demands a holistic approach involving organ screening, serology, and early intervention. So, Dr. Yogesh summarizes that CTDs are like a multi-system puzzle. SLE, malar rash, nephritis, arthritis, and photosensitivity are classic findings. Systemic sclerosis, skin tightening, Raynaud's, esophageal dysmotility, and lung fibrosis are hallmark signs. Dermatomyositis or polymyositis, proximal muscle weakness, heliotrope rash, and Gottron's papules are defining features. RA, overlap CTD, symmetrical polyarthritis, and prolonged morning stiffness are signature features. Sjogren's syndrome, dry eyes, dry mouth, and parotid enlargement appear in most cases. MCTD, mixed features from lupus, scleroderma, and myositis accurately describe this overlap syndrome.